Thank you very much. I would like to thank Yashoda Hospital, Dr. Pagan, Dr. Arun, for inviting me to give this talk. It's good to see familiar faces here from India, and obviously my mentor, Dr. Hervé, whom I met in Marseille in 2007. So my talk is on the management of benign airway stenosis. I'll be focusing in post-TB and post-intubation airway stenosis. I won't be able to complete my talk without showing these photos. Dr. Dumont there, or Professor Dumont there, obviously, who inspired me to take up rigid bronchoscopy, and obviously Dr. Hervé at the bottom there, whom I met in 2007, Dr. Hervé. And the Ravindra Mehta was there also with me. Dr. Green, Dr. David Breen from Ireland was there. And then our colleague from Morocco or Tunisia, and I can't remember now. Next. So these are the objectives of my talk: to examine the current management option for benign airway stenosis, identify patients who may benefit from surgical versus endoscopic options, and evaluate the current literature supporting the management options of benign airway stenosis. Next. So there are many causes of benign airway stenosis already covered by Dr. Arun. So I'm just going to focus on post-intubation and post-TB stenosis. Next. So in terms of the management of benign airway stenosis, I think we need to evaluate the underlying etiology, whether it's from infection such as TB, is it related to a systemic disease such as vaginous, or related to previous trauma such as intubation. We also need to evaluate comorbidities and the ability of the patient to tolerate procedures. Next. But the question is, in our mind is always, what is the best management for benign airway stenosis? Is it surgery or is it endoscopic approach? So, and then you see that endoscopic approaches, we have stents and bronchoscopic dilatation. So this endoscopic approach meant for as a bridge to curative surgery or palliation if the patients are unsuitable for surgery, or are they for restenosis that occurs after surgery? So these are some of the questions regarding the best management for benign airway stenosis. And then we also need to qualify the population, likely that we are going to focus on patients with non-systemic diseases such as TB and post-intubation. And then what does the literature say? Well, the surgery is always the gold standard, but does it really say that? Next. So surgical resection is always considered the gold standard. However, it's actually reserved for those who are eligible for surgery. But the downside is it is uncommonly performed, and it is highly technical with significant post-operative care requirements and management, and it is likely dominated by a few major referral centers in the world. Next. And just to share with you my experience with regard to surgery in the post-TB stenosis, chest X-ray number 1 there was the first presentation of a young female with left lung collapse secondary to post-TB in 2015. And then we did dilatation and we put a silicone stent there. Left lung re-expanded, but the patient couldn't tolerate the silicone stent, and the patient was referred to our thoracic surgeons for sleeve resection. And she underwent sleeve resection, but the left main stem stenosis recurred. And then chest X-ray number 3 there showed that what it looked like after we did laser to open up the stenosis, and then 2 years post laser, the left lung remains aerated without any intervention in chest in the last chest X-ray there, and the patient is well. So what about stent in benign airway stenosis? I know that Marseille does a lot of stent by Dr. Hervé. So we know that stent can relieve airway obstruction, stent can provide immediate relief of respiratory distress or failure, but stent can cause complication and can be very difficult to manage. And just a word from our friendly surgeon, silicone stent or expandable stent, even if coated, appear inadvisable to treat benign airway stenosis. And they feel that stent should be used only when curative surgical interventions are not feasible or are contraindicated. Next. So what is the problem with evidence-based interventional pulmonology and or airway disease? So the problem is most of the literature is case-based and retrospective, and designing and executing randomized control trial in interventional pulmonology can be difficult because of ethical concerns and selecting patients with comparable comorbidities and disease processes and double blinding procedures can be difficult. Next. So just look at this paper from BMJ in 2003. So what about parachute? So we know that parachute can reduce the risk of injury after gravitational challenge, but their effectiveness has not been proven in randomized control trials. So just because there are no randomized control trials in parachute doesn't mean that we shouldn't be using parachute to prevent death. Next. So the first part of my talk is about post-TB airway stenosis. I'll try to fast forward in the interest of time. So I think post-TB stenosis is well known in this part of the world, in India, in Malaysia. So I think there's nothing very new about the facts about post-TB stenosis. We know that most of the TB cases can be cured by appropriate medical treatment, but sequelae and complication can happen, including airway stenosis. Although in the West, benign stenosis of the airway is often iatrogenic, such as prolonged intubation. But in TB endemic countries, endobronchial TB is a common cause of airway stenosis. Next. And again, I think there's nothing new about this slide. If you are working in India or Malaysia, endobronchial TB is something that we face. This picture just shows the fibrostenotic type of endobronchial TB. Next. And just to show the many types of endobronchial TB, the classification by our friend from Korea, from the caseating type to the tumorous type, the bronchitic type. So I don't do flexible bronchoscopy routinely in patients who are smear positive. So I don't see this kind of appearance in Malaysia. But this is one of the classification of endobronchial TB. Next. And then, so who are at risk for endobronchial TB? In Malaysia, my personal observation, young female and those with longer symptoms duration, more than 4 weeks. Next. So post-TB stenosis was first described in 1689, and it is under-recognized and is often misdiagnosed, sometimes misdiagnosed as asthma. And stenosis can develop many years despite adequate anti-TB chemotherapy. And steroid has no influence in terms of outcome of endobronchial TB. Next. And the left main bronchus is the commonest site. So based on my observation in Malaysia, and unlike post-intubation stenosis, post-TB stenosis can involve both the trachea and bronchus, making management very, very difficult. And therefore, early diagnosis is important to control obstructive symptoms. Next. So they just, okay. And symptoms, I don't have to repeat these. We all know the symptoms of airway obstruction, central airway obstruction, wheezing, stridor, dyspnea, recurrent pneumonia. Next. In terms of imaging and diagnosis, I think we are all familiar with the diagnostic test, chest X-ray, and then normally we do followed by 3D reconstruction of the CT scan to establish the dimension of the lesion and to assess whether if the airway distal to the lesion is patent and the relationship to other structures like vessel. And generally, we will do flexible bronchoscopy as the next step. To help in the planning for further intervention. Next. So the treatment for post-TB stenosis, again, surgical resection and reconstruction is the preferred therapy for post-TB stenosis, but we know that not every patient is eligible for surgical resection. Patients may refuse, and then the anatomical limitations, long segments, Malaysia, severe stenosis, and multiple level, poor lung function, and then complication of surgery such as anastomotic leakage, requiring re-anastomosis, and then re-stenosis even after surgery. Next. So what are the non-surgical options? Next. So the indication for endoscopic intervention, again, the obvious symptoms, dyspnea, post-obstructive pneumonia. Next. And should we wait until the patient is smear negative before we do intervention? Well, I think if possible, we can wait until the patient is smear negative, unless the patient present with life-threatening central airway obstruction, in which case we will have to go in regardless of whether the patient is still smear positive or negative. Next. So these are the endoscopic approaches in the management of post-TB stenosis. As you can see there, there's nothing unfamiliar to us, I think. Balloon dilatation, mechanical dilatation, mitomycin C. After dilatation, some people don't believe in it. Stenting and laser. Next. Just to show just to show the video, a short video. Again, there's nothing new about this technique, balloon bronchoplasty for post-TB stenosis. The balloon is inserted through the side port of the rigid bronchoscope. Next. And then mechanical dilatation. One of the cases that we did in my place, post-TB stenosis, I think after balloon bronchoplasty, we did mechanical dilatation. Next. And then what about recurrent? Yes, recurrent is not uncommon after dilatation. And so what do we do to prevent recurrent or to slow down the onset of recurrence? So this is my practice. Again, nothing unusual about this. I apply mitomycin C, and in some cases, if mitomycin C doesn't work, I'll put a silicone stent if that is possible. Next. So what is mitomycin C? It is an antineoplastic agent that inhibits fibroblast proliferation and development of granulation tissue. It has been shown to have some benefit in delaying recurrence of post-intubation tracheostenosis, but its use in post-TB stenosis has not been well described. Next. So again, this is just to show how we apply mitomycin C after dilatation. Next. Okay, just to show a quick video, one of the cases that we did 3 years ago, post-TB stenosis, we did dilatation, and that was followed by mitomycin C application. can you fast forward the video, Eric, just to save time? Yeah, so that's just to show mechanical dilatation, and then fast forward, okay, and this shows the mitomycin C application. So nothing, nothing extraordinary about this. Next. Okay, just to share with you one publication, just a case report. One of the cases that we did successfully. It's a multi-level post-TB stenosis, actually, which we managed to manage with balloon bronchoplasty followed by topical mitomycin C without putting a stent. Next. So what about stent? So sometimes I'll put a stent in TB stenosis if mitomycin C doesn't work, or if there is presence of Airway Malaysia. Next. So there are a few types of stent. So we know that Professor Dumont introduced the started silicone stent in 1990. So we have silicone, metal, and hybrid stent. Next. So what are the advantages and disadvantages of silicone stent? You can find this in any IP textbook. So I think the main thing about silicone stent is the need for rigid bronchoscopy to deploy the silicone stent. Next. So the timing, in terms of timing of silicone stent removal in post-TB stenosis, I think more or less we are talking about between 6 to 12 months. Next. Just to show a short video of a case of post-TB stenosis where mitomycin C didn't work, so we had to put a stent. So you can fast forward the video, Doc. This balloon bronchoplasty. Can you fast forward? Yeah, so lumen restored. Fast forward. Can you fast forward, Doc? Yeah, that's the stand that we deployed. Quite challenging to deploy the stand in the left main bronchus. Perhaps for sure, the Prof. Hervey can do a better job than me. So this is what we did to unfold the stand in the left main bronchus. Can you just show the end product, Doc? Right at the end there, can you fast forward? So we had to use a balloon to unfold the stand. Fast forward, Doc. Yeah, so ultimately we managed to unfold the stand there. Fast forward a bit more, just to save time. Yeah. So in this case, we use a balloon to unfold the stand. Okay. Next. Okay, so laser, just a few case report on laser in post-TB stenosis. To me, I think it is a complementary therapy and it's not recommended to be used alone. So it probably has to be used in conjunction with balloon bronchoplasty and balloon bronchoplasty. Next. So this is the publication on laser in post-TB stenosis, showing the improvement in the lung, in spirometry, the flow volume loop before and after laser. Next. So what about the outcome using the endoscopic approach in post-TB stenosis? This is a paper published by Professor Philip Eng from Singapore in Journal of Bronchology many years ago. so he had 21 patients in this paper. So 14 patients had only one procedure, and then you can see the outcome there. Half of them remain asymptomatic, but some remained symptomatic. 2 patients had 2 procedures and had restenosis. 4 patients had 3 procedures, and 1 patient even had 5 procedures. So in terms of the outcomes, it looks like maybe perhaps the majority had good outcome, but some some developed complications, some required pneumonectomy, and some remain symptomatic. So it seemed that the result is mixed. Next. What about my own experience, unpublished data, just a small series, 7 patients, we put stent in 4 out of 7 patients. So, and one of the stent migrated. But the outcome, 4 of them had patent left main bronchus, but some continue to have recurrent stenosis, and one of them even had 5 procedures, and we even plan to put a stent. Yes, and so we had some success, but we had some failure as well. Next. So that's about post-TB stenosis. Now I just going briefly about post-intubation stenosis, which mainly affect the trachea. So again, post-intubation stenosis is due to the use of high pressure, low volume cuff endotracheal tube, and so now our practice now is using high volume, low pressure cuff endotracheal tube. But in spite of that, post-intubation tracheal stenosis is still not uncommon. So this is what it looks like. The endotracheal tube that we use, the high volume, low pressure, and this is the old one, the low volume, high pressure endotracheal tube, which causes tracheal ischemia and necrosis, leading to post-intubation tracheal stenosis. Next. So again, the treatment, whether surgical or endoscopic, in my opinion, needs a multidisciplinary discussion involving pulmonologists, thoracic surgeons, and ENT. The mainstay treatment remains surgical, but it is not without risk, just like in post-TB stenosis. And the fact is that surgery cannot be performed in all patients, and that one we know. And again, the endoscopic methods may be the only alternative if the patient are not eligible for surgery. And the endoscopic methods are familiar to us: rigid dilatation, mitomycin C, laser, plus minus stent. And relapses are not uncommon. Next. So what do we do? I think, to me, it should depend on what I see, whether it is the stenosis in the trachea, whether it is subglottic. If it is in the subglottic area, I don't intervene. I will leave it to my ENT surgeons to intervene. And whether it is web-like or complex tracheal stenosis. So I tend to manage simple tracheal stenosis. The complex ones will be discussed in our MDT meetings involving thoracic surgeons and pulmonologists, as well as ENT surgeons. Next. So surgical comments on post-intubation tracheal stenosis, about stents. So this is what the surgeons say. Rarely would a silicone stent be considered as a bridge to resection, and never should an expandable stent be considered at all. And tracheal reconstruction procedure should not be undertaken without considerable study and experience. So the word here is considerable experience. So we know that, there are not many centers in the world, I think, that perform tracheal reconstructive procedures. So I think it's not easy to gain considerable experience. And what about silicone stents? Again, silicone or expandable stent, even if toted, appear inadvisable to treat benign stenosis, since they not only produce severe stenotic lesion, but may make future definitive repair impossible. So these are words from our friendly surgical colleague. So what about the data regarding tracheal resection? I just got this paper on anastomotic complication after tracheal resection. I think one of the centers in the US. It was a retrospective review data from 1975 to 2003. It is a large international referral center for tracheal disease. They perform 22 cases per year. And looking at the complication here, the one that I highlighted in the rectangle there, the post-intubation tracheal stenosis, the complication there, overall 18.5%, anastomotic complication 11%, and low mortality there, 8 patients there. So in terms of predictors of anastomotic complication down there, in table 4, the length, whether the patient had preoperative tracheostomy, young age, diabetes, reoperation, and laryngotracheal resection. So I think overall, the result of tracheal resection are acceptable in terms of the complications and mortality. What about data for bronchoscopic treatment for benign tracheal stenosis? Just going down in table 2 there, type of stenosis, simple stenosis there, the cure rate is almost approaching 100%. And for complex stenosis, it is almost 70%. And looking at the type of endoscopic the treatment choices used there, I think there's nothing unusual about the procedure there. I think we all do these procedures routinely: rigid bronchoscopy and debulking, flexible balloon dilatation, APC, laser, cryotherapy, stent, even mitomycin C application. All right. So overall, in this paper, it seems that endoscopic approach is an acceptable technique in the management of benign tracheal stenosis. Next. So just to show my own work, although it was just a case report many years ago, we published our work when I was first starting rigid bronchoscopy, successful treatment of tracheal stenosis by rigid bronchoscopy and topical mitomycin C. Next. Yeah, if you can, Doc, you can show play the video. Next. Okay. No, the next one. No, the one before. Yep. At 12 months. Yeah. So this is the end result. At 1 year, the tracheal lumen remains patent, and we didn't need to put a stent. Next. However, mitomycin C doesn't always work. Just to show you, one of the cases, post-intubation tracheal stenosis, we had to put a stent because the stenosis recurred even after we put mitomycin C. Just to show you. So to me, putting a silicone stent is always a very challenging procedure. So in this case, we managed to put a stent. Yeah, successfully. Yeah. Next. So my last slide. So I think in summary, a number of endoscopic options exist for benign airway stenosis, but in my opinion, no single technique is satisfactory, and all these endoscopic approaches are palliative, and they tend the stenosis tend to recur, and patient need repeat sessions. There are complications with stents, and but sometimes these endoscopic approaches may be the only alternative in patients who are not suitable for the gold standard curative surgical resection. And I think patients who have complex airway stenosis should undergo the cases must be discussed in a multidisciplinary approach in the evaluation of surgical versus non-surgical management option. And then I think the mechanism of obstruction, the extent, location, morphology, etc., etc. These are factors that determine the need for surgical or bronchoscopic intervention. And I feel that we still need to find better techniques to manage benign airway stenosis. Thank you very much.